introduction to musculoskeletal ultrasound. And about musculoskeletal ultrasound, we are specifically going to talk about the role of ultrasound in MSK imaging, the evolution of MSK, musculoskeletal ultrasound, the growth, and the sonoanatomy. So, our introduction, like Mr. President addressed us, a one-day presentation cannot make us good, but this is an insight to open our eyes to the possibilities that can be achieved. So the objectives, by the end of this presentation, the participants will be able to appreciate the origin, evolution, and the increasing role of musculoskeletal ultrasound, and describe the sonoanatomy of the structures imaged. This point in case has been a challenge. Of all the orthopedic surgeons in Uganda, they think that if someone has an MSK injury, first line is a plain radiography. Then if you don't see much, you end up using MRI. So I was working with one, and he sent a patient. I did knee X-ray, and I ended up doing a knee ultrasound. And when he saw it, he said, no, for us when we are studying these things of knee ultrasound, we are not there. And I don't really trust them. I used to trust one radiologist, one of my mentors. So in my absence, he wanted to prove. He sent the patient to Kampala Imaging Center with a request. This person should be worked on by Dr. So and so. And she worked on her, on the patient, came back with the results. And the conclusion was similar. And he called me and said, hey, you mean this thing is possible all along? So even the physicians we work with are not really aware the role of ultrasound in what? In musculoskeletal imaging. So, and people who are in teaching can attest to this. We are using the word appreciate. Appreciate. I chose it specifically because at the end of this, there is no assessment. You cannot measure the knowledge people have attained. That's why the term is appreciate. Then this one we shall be able, because this is just a review, a recap of what we already know. And as you are going to note, in this field of ours, imaging and radiology, we Africans, I think we are not even asleep. We are in coma, a serious one. Everything we want to do, we are relying on either the Americans or the Europeans. And sometimes the differences between them are as gross as their table manners. People in the UK cut with the right hand and eat with the left, which would be an offense to the pastor and me. Actually, all Christians. I think even when you are left-handed in Africa and you eat with your left hand, your parents beat you to learn to eat with the right hand. So the differences between the two sometimes are as big as that. Me, I'm not a fan of America that much, but they say no one can be bad completely. There is always some good thing about the person. For them, they cut with the left and eat with the right hand, which differs from the Britons and Europe. So as you see, they are always in a competition, who does what first. And that is realized in the money they put in research. When you ask us in Africa here, how much money do we invest in research? There isn't any. So we shall not in the foreseeable future develop our own protocols, but we shall completely depend on what our colleagues give us. And fun enough, we don't even put it to a test. We just continue. And I think that is a very bad habit on our side, to an extent that we don't even know the normal reference values of abdominal structures for an African population. When you find a liver greater than 15.5, you say that is a hepatomegaly. But you might find that the threshold for Africans should even be less, at around 14 or more. So we are doing a lot of overdiagnosis and underdiagnosis because of that. So to run away from that sickness, I think Sork should organize some funds for people to continue with research, like such endeavors. Nelly and you can bore a reef, anatomy and ultrasound skills up that side. We are venturing into a study to establish the normal values by ultrasound. So you can get the same study objectives and replicate the same study in Kenya. It will not be hard. So the current status, this is about the rising role of MSK in imaging. Current status, effective and established. It is a first-line imaging technique for musculoskeletal pathology, and the reasons are known. There is no trauma involved, and there is no radiation.
What is your mic?
You want to give me this one? Okay. So the current status, it's the first line imaging technique for musculoskeletal pathologies, and more so the non-traumatic. I'm happy that Richard is doing a study of shoulder in non-traumatic patients. So global adoption, it's a well-established primary diagnostic tool in Europe as we talk. Global adoption in North America, rapidly gaining popularity. And that is evidenced by the high demand of MSK teaching courses. You see, even in our presentation, Africa is not mentioned. We are forgotten. So the key drivers for the growth of ultrasound imaging in MSK, these are ongoing technological advancements. I believe all of us can attest to this. It's only the Gen Zs who cannot. They have come up in the era of supercomputing, where machines do things in an easy and more sophisticated way. But for us who started a long time ago,
it's like your pointer is not moving.
For us who started, for us who started a long time, the quality of the images was too. The quality of images was too grainy. But now with new advancements like tissue dynamic imaging, tissue harmonic imaging, and dynamic contrast enhancement, the images are comparable to those of MRI. And these people, the whites, never sleep. They keep looking for new things to use. There is a recent machine Mindre Pennate and his colleagues installed in Uganda. It has features never seen. There is AI guidance as you work. There is elastography, there is microsaturation, and the contrast enhanced ultrasound, which we are not using in Africa. I don't know if there is any place using it in Kenya. You have any center using contrast enhanced ultrasound? Aga Khan. Because of the legal challenges, the contrast is not, as your drug enforcement approved the use of contrast in MSK imaging and ultrasound. Okay. So, critical considerations. Ultrasound is highly operator dependent. Actually, it relies on the examiner's skill. That's why someone doing an imaging course, in all the medical field, imaging is the most evolving field. Every day newer technologies. Yesterday I was talking to my colleagues from Kenya, and I was simply asking them about how many sequences of MRI they use. And at most, I think Kenya is more advanced than us when it comes to MRI. They are using around 8. The last time I checked MRI, I saw a book with 150 sequences. And I went and asked a medical physicist, why sequences? And he told me diagnosis depends on the sequence you've used. So even on that side, we need to improve. So the other thing is demanding a knowledge base. And the knowledge base we are talking about is the APP I talked about. Without a good foundation of anatomy, pathophysiology, and physics, things will be challenging. So this is the history of MSK. In 1942, ultrasound was first used as a medical imaging modality. 1958, that's when they started using it as in MSK imaging. and they were using it to assess acoustic attenuation of tissues. First automatic scanner developed, and this enabled broader use. Ultrasound started with static scanners, and the machine was very big and the probe was big. It could not get the images we are getting. It was like taking a photo at a particular point. It could not capture sine loop, which you can pause and play back and get where you actually want to be. Ultrasound was primarily limited to abdominal and pelvic diseases. And it had limitations with OBS because of the fetal movement. So it would only scan structures which had no motion at all. So current status and growth. Today it is an effective and established first-line imaging technique in MSK pathology. And one of my colleagues got a job in the UK, and he told them he does MSK. So the first examination they gave him was anterior abdominal wall. And the man said, "No, I told you I do MSK." So for him, he thought MSK was about shoulder joint, elbow joint, wrist joint, hip, knee, and ankle. So they told him, no, anterior abdominal wall is MSK. And like I told you, learning is continuous. Working with specialists can sharpen your mind. I learned to do lumps and bumps, not formally, but from the inquiry from these surgeons you work with. They see mass, they want you to check it for them. You check it for them, you get lost, you go and read and find the solution. So in Europe, like we said, it's well established already, and North America is gaining popularity. Key drivers, we mentioned them, still there, improving technological developments and the clinical applications. You might find that in Europe it is hard to do any intervention without ultrasound. You need that level of certainty, that way I'm putting the injection may be like in knee, in treatment of osteoarthritis, you are putting the injection at the right place, the drugs. So the ultrasound advances include high-resolution linear array transducers, extended field of view, tissue harmonics, compound imaging, and recently array forays into 3D and 4D imaging using musculoskeletal imaging. Previously, we could not even try to see the cruciate ligaments, but now with compound imaging, you can have a glimpse of the cruciate ligaments. And as I've told you, for us, we are not even sleeping, we are in coma. I think the whites are working hard between the competition between Europe and America, who will produce the first ultrasound technology that can image cruciate ligaments. So now we can, this is something we've been doing. We are just revisiting the gross and sonor anatomy. So we are going to look at structure of skeletal muscle. So the gross structure, we have the investing layers, which are the connective tissue framework. We have epimysium, invests the entire muscle. Recently at Ernest Cook, we are lucky. Most people who are teaching imaging do not have cadaveric dissection. There you read a textbook, you go to the cadaver room, look for what you want. They get a muscle and show you all these layers. Then you go to a virtual table and proceed with that virtual reality. The emphasis is to help people ground anatomy before they move into the imaging anatomy. And I don't know if it is the case here. The anatomy exam for imaging students is funny. They teach them gross and introduce the imaging anatomy, and their exam is about imaging anatomy, and it is labeled anatomy, gross anatomy. But everything is imaging in it. So, like I've been saying, this is a language. These things can be challenging if one wants to cram them. I remember even when I was a student, MSK appeared to be one of the hardest. It seemed, because the consultant who was teaching it said, I'm going away for 2 weeks, but the course unit has started. By the time I come back, you should know all the muscles of the body from here to the small toe. So we delved into the muscles and nerves, innervation, saturation, drainage, insertion, and origin, and things looked challenging until one of our colleagues, she's an Indian now, she's working in the UK, said, I think we are in trouble. We are using the wrong textbook. That Gray's Anatomy. She said, I've got a colleague who has given me a soft copy of Gray's Anatomy for students. When we used that one, things started to become easy. But still, these words, these ones, were giving us a hard time. Lucky enough, I had a textbook of anatomy which I was not using, anatomy unit and form. When I opened the chapter of muscles, musculoskeletal, it had made this work easy. It was defining the meaning. It gives you mesium, then it tells you what epi means, what peri is, and what endo means. So now things started making sense without cramming. Like you see, epi is before. Then peri, around, and endo, inside. When you look at them in this way, you understand better that epimysium invests the entire muscle. That's why you see it is before the muscle. It surrounds it. Then peri envelopes each fasciculus, a band of fibers. And endo separates individual fibers derived from perineum. And I think many of us today, for lunch, you are going to have meat. Let the lesson continue from there. As you are eating the meat, try to, if they give you muscle, try to see that you find these. And usually these, they don't have, you have supporting structures like nerves, blood vessels, run within the connective tissue framework. So this is what we have been talking about. This is an illustration. you can see that epimysium is before the whole muscle. And the peri is surrounding a muscle bundle, and you pull one from this inside, from this, the smaller, the inner unit now, a muscle fiber, it is covered by an endomysium. And this, I don't know how you call it in Swahili, the fasciculus are those stripes you clearly see in a muscle. And from these, as they move towards the muscle ending, they form one common sheath, which will be the tendon of that muscle. So the microstructure of a muscle fibers, individual cells, and cylindrical or prismatic in shape. Fiber size up to 1.5 inches. This is highly variable. Ig sartorius fibers are up to 2 feet. Sartorius, I believe, is the longest muscle. It starts somewhere here and ends this way. Now you can imagine if you have a dinka, how long that muscle would be. Or a Rwandi, someone who is 6'8". So the fibers are in breadth 0.02 inches. The fascicula, this is the plural of fascicula, prismatic band of fibers. This alignment may be parallel or oblique to the muscle's longitudinal axis. So the sacrolemma, the sheath surrounding each individual fiber. Ultrasound correlations, the connective tissue framework, the perimysium, epimysium, generates typical echogenic striations seen on ultrasound. Knowledge of fiber orientation and compartmental structures is essential for accurate assessment and avoiding anisotrophy. Anisotrophy is an artifact seen on ultrasound because MSK uses B-mode imaging, and the hallmark of B-mode imaging is perpendicularity. A structure which is perpendicular to the B-mode beam will be better demonstrated. The more the angle tends away from 90, the structure starts appearing as hyperechoic. So as we are imaging, we should not take note of that, because most structures have a curve. If you are doing MSK of the shoulder, as you can see, if you try to image this, there is a curve. If you go to the elbow, it is also curved here. Even what you think is straight here is also, even the posterior. So we always use the heel toe maneuver to overcome this anisotrophy issue. Origin, insertion, and attachments. This we are still using, but the recent terminology anatomica has discouraged the use of origin and insertion for muscles, because the origin and insertion can change role depending on the position. So we have insertions or attachments. So the muscle has an origin, a belly, and an insertion, or it has insertions and a belly or attachments and a belly. That's the current terminology. Attachments, muscles are attached to bone, cartilage, ligaments, and skin, and can be multiple. When I read this, I asked myself, which muscles are attached to skin? Does anyone have an idea which muscles are attached to skin? The commonest example is this one here. Many of us, when we get old, there is a surging of this. But there is a muscle there, if you exercise it, that surging disappears, called the platysma. And the one is responsible for giving us good pimples on a cold day. The most important one is the deltoid muscle of the scrotum. Those who are parents, you see how they behave on their children. In a cold weather, they shrink. On a hot day there, it's relaxed and hanging. Even when you are doing ultrasound and pour cold gel on the scrotum, you tend to have a cremasteric reflux. The muscles will contract and shrink. So the definition of this one is no longer valid. That's the attachment of the greatest movement. So either way, depending on posture, the muscle can change. So this was another image to remind us of what we have covered. And now this one is a nerve. You can see that the arrangement is similar, but what is contained inside is, and this now you hear the new word has come. The word mesium is from myo, which is muscle. Now this is neurium from neuron, which is a nerve. And the labeling doesn't change. Perineural, epsiliocellular, perineurium, endomerium, perimerium. And when you get to know these basic things, ultrasound becomes easy, because you will not be cramming, you will be understanding things from memory. So, fiber architecture and orientation, parallel arrangements. This one becomes a challenge in MSK because muscles are arranged differently. There are those which have parallel fibers, there are those which have feather-like fibers, there are those which have quadrilateral. And usually the muscles are named by the bone or the work they do or their shapes. If you understand that, life becomes easy. An example, deltoid is labeled deltoid because it's triangular in shape. You have rectus abdominis, where rectus means straight, so it ends up being straight muscle of the abdomen. Then you find rectus femoris, you see that straight muscle of the femoral area. Quadratus femoris, this one is labeled quadratus femoris because it looks like a square, quad. Curved fibers tapering to tendon at both ends, e.g. biceps muscle, which is a fusiform. I don't know, the people here, we have Gen Zs. We used to watch this movie, Commando. But the Gen Zs, I don't think they have watched. You remember when Arnold Schwarzenegger was carrying a trunk of a tree, and this muscle was very prominent. The biceps branch, meaning it has two heads and of the brachium. So fiber architecture is very important to note because it gives you a way to image when you are doing ultrasound. The way you image the deltoid is not the way you would image the rectus abdominis. You must get the technique, and that's why anatomy is important, because now it has three parts: anterior, middle, and posterior. So you know that when you are imaging the deltoid, you must go through all the three. Triangular, wide origin, covering a narrow insertion. An example of that muscle is the infraspinatus. And this one could be misleading. This one you have to know, because infraspinatus, they didn't give the location. And it means infra, it's under or below a spine. And they didn't mention which spine in this case. So sometimes the nomenclature is an issue, but infraspinatus is this muscle here. You are going to find it when we talk about the shoulder. And I believe Richard will talk about it. We have muscles that have a pennate or feather-like appearance. Fibers are oblique to the tendon. You can have unipennate or bipennate. Tendon is on one side and fiber is inserted along its length. It gives the extensor digitorum longus. Now you see the nomenclature here is about the work of that muscle. This does extension, digitorum are the digits, and longus. When we come to these muscles, the one we are talking about, extensor digitorum longus, it is a muscle here in the forearm, but why it is called longus, it is starting from the arm and crosses the wrist to do its work this way. Like now this is flexion, and the extension will be this. So it is a posterior muscle now. Someone should know that it is what? It's on the other side of the arm. Because this is flexion, what takes it back is that. And a most amazing thing I found my colleagues when I had just graduated doing the wrist and the arm. And they were finding it hard to get the muscles of the thenar eminence. And I told them there are 4 muscles which you can understand by doing the action they do, because all of them were named for the action they do. If you do this, you have opposite, now that one is opponens. If you do this, that is adduction. If you do this, this is abduction, this is adductor, and you have all the muscles depending on what they do. And one of the famous anatomists would also do the nerves like that. He would just pocket here, and each hand was pointing to a nerve. and things became easier for students. So multipennate have central tendon with circumferential fiber insertion, like the tibialis anterior. So this one you can relate to the tibia, and you know that the muscle is just close to it. The bipennate central tendon with fibers inserting obliquely is rectus femoris, which is a straight muscle of the femur. So normal sonographic anatomy of muscles. Now you've seen, depending on how the muscle is shaped, dictates how you image it. If you are doing this for femur, problongitudinal for rectus femoris, you are getting short axis of the muscle fibers. But if you oblique your probe, you are getting the long axis of the muscle fiber itself. Those are the things that seem to make MSK challenging, because it does not conform to the sagittal and transverse orientation we are used to in abdominal gynecology and mostly OBS. So those are some of the things that would make someone think that MSK is hard. So you are imaging longitudinal plane appearance. So what you call sagittal in MSK could be an oblique probe orientation. And I've come across this problem even in abdominal. When you are teaching students abdominal, you tell them to give you longitudinal axis of the pancreas. What comes to their mind that if the probe is transversely put, that must be the short axis. So that deviation from the norm sometimes is a source of confusion in MSK imaging. And the other one is, in MSK, many people don't mind about the probe orientation. As long as you get anatomical structure to give you reference and point to the direction you want, no one will question that you didn't do image orientation of the probe. So fasciculi identified in longitudinal planes as hyperechoic cylindrical structures separated by hyperechoic connective tissue, the perimysium. Not discernible individual fibers and endomysium. So this is ultrasound cannot go to this level of histology. So supporting structures, you have thin and linear hyperechoic epimysia and fascia intermuscular fat. So fiber architecture is very important to note when you are going into MSK. Ultrasound can differentiate all muscle fiber arrangements: quadrilateral, fusiform, triangular, unipennate, bipennate, and multipennate. But as you see, this will depend on your knowledge of anatomy, of how this muscle is aligned according to the bone you adjacent to it. So you have illustration of muscle structure. This is one which is fusiform. This is a bipennate, and this is a unipennate muscle. So a small pause.
Then we go for tea break, then we come back.
I thought we are okay. Let me finish this and the next thing. So let's finish the muscles and you get a tea break. Then we continue with other structures like tendons, cartilage, and nerve. normal sonographic anatomy of muscle. This is now where ultrasound beats all the other imaging modalities. When you are doing an MRI, the patient is in the gantry, and if you're imaging the shoulder, no motion. If you do motion, you get artifacts. But with ultrasound, you can do dynamic assessment. As you see, when it comes to the shoulder, Richard will be demonstrating how we can get to no impingement, which MRI can always miss. So during contraction, like that image I'm talking about of Arnold Schwarzenegger when he did this, or Andrew Coleman, the fibers contract and they form a bulk here, which we are going to see on an image. So apparent increase in muscle bulk, hypoechoic fascicles appear thicker, muscle takes a more hypoechoic appearance overall. Clinical PAL, when comparing contractile muscles, ensure they are in the same state, relaxed or contracted. So if you are doing comparison, which is also another advantage of ultrasound over other imaging modalities, you can easily move your probe from here to here, to the contralateral side. But it will not make sense if you are comparing this arm, like you are imaging biceps, and this one was open, then you compare with the contralateral side when it is in this position. This is not acceptable. It should be either both or. Yes, those are some of the common issues we face. So this is an image showing muscle contraction, transverse ultrasound image of anterior and mid-arm biceps, short and long heads. Now you hear this word short and long heads. This muscle is called the biceps because it has two, the short and the long head. And there is another one here which confuses. I don't know if this Nelly and Richard can attest to it. Imaging this part tends to be very hard for students. This triangle here, because you are imaging tongue muscles and extra tongue muscles. There is one which also gave me challenges, the digastric. When you hear gastric, what comes to your mind? Stomach. And now I was wondering, why are they here? That takes us back to the language of the terminology. Gastric means belly. So this means two bellies. Then I said, okay, now it makes sense. So this image here is a muscle before contraction. This is the biceps branch. This is the long head and that is the short head. Now with contraction, you see how it has thickened. And when you compare, it became more hypoechoic relative to the non-contracted state. Why do you need to understand this? This, you can easily interpret this for pathology if you don't know that under normal sonography, when the muscle contracts, it becomes less echogenic compared to its non-contracted state. So with this, we have finished the muscles. And after the tea break, we are going to continue with the disturbing thing which also gave me some hard time with the surgeon on the anterior abdomen, the deep fascia and the superficial fascia. I worked on the patient and I could not write the report because my anatomy in that region was lacking. So with that, I believe at this juncture we can pause and proceed after the tea break. Thank you for listening.
Welcome to RadMed, your 360 degrees radiology and healthcare partner. Shop for all your radiology needs, from X-ray machines to ultrasound machines, we have it all. At RadMed, we are dedicated to revolutionizing healthcare. We are experts in radiology and healthcare equipments, serving all areas in Kenya. Why should you choose RadMed? Firstly, we provide high quality and reliable modern technology hospital equipments. Secondly, we provide personalized support for every client. Thirdly, we have a proven track record in successful installations. Globe Care Hospital in Eastleigh, we machines to ultrasound machines. Firstly, we provide high quality and reliable modern technology hospital equipments. Secondly, we provide personalized support for every client. Thirdly, we have a proven track record in successful installations. Globe Care Hospital in Eastleigh, we delivered and installed an X-ray machine. Lydia Key Memorial Hospital, we delivered and installed an X-ray machine and a computed radiography machine. In Calvary Hill Hospital, we delivered and installed an X-ray machine with a CR. In Ziwa Hospital, we delivered and installed an X-ray machine with a complete CR. In Mwanzawetu Health Services, we delivered and installed a colour Doppler machine with 2 probes. Brooks and Cherith Hospital, we delivered and installed an X-ray machine with a CR. In Nanyuki Hospital, we delivered and installed an X-ray machine. Esobi Healthcare. Malkia Wings Hospital. Zenit Care Hospital. Nelly Nursing Home. Pro Care Cottage Hospital. Esther, a radiology entrepreneur. Itak Hospital. Peter, a radiology entrepreneur. Mugamo Medical Centre. Jabs Medical Centre. Why should you choose RadMed? Firstly, we provide high quality and reliable modern technology hospital equipments. Secondly, we provide personalized support for every client. Thirdly, we have a proven track record in successful installations. Welcome to RadMed, your 360 degrees radiology and healthcare partner. Shop for all your radiology needs, from X-ray machines to ultrasound machines, we have it all. At RadMed, we are dedicated to revolutionizing healthcare. We are experts in radiology and healthcare equipments, serving all areas in Kenya. Why should you choose RadMed? Firstly, we provide high quality and reliable modern technology hospital equipments. Secondly, we provide personalized support for every client. Thirdly, we have a proven track record in successful installations. Globe Care Hospital in Eastleigh, we delivered and installed an X-ray machine. Lydia Key Memorial Hospital, we delivered and installed an X-ray machine and a computed radiography machine. In Calvary Hill Hospital, we delivered and installed an X-ray machine with a CR. In Ziwa Hospital, we delivered and installed an X-ray machine with a complete CR. In Mwanzawetu Health Services, we delivered and installed a colour Doppler machine with 2 probes. Brooks and Cherith Hospital, we delivered and installed an X-ray machine with a CR. In Nanyuki Hospital, we delivered and installed an X-ray machine. Esobi Healthcare. Malkia Wings Hospital. Zenit Care Hospital, Nelly Nursing Home, Pro Care Cottage Hospital, Esther, a radiology entrepreneur. Itak Hospital. Peter, a radiology entrepreneur. Mugamo Medical Centre. Jabs Medical Centre. Why should you choose RadMed? Firstly, we provide high quality and reliable modern technology hospital equipments. Secondly, we provide personalized support for every client. Thirdly, we have a proven track record in successful installations. Welcome to RadMed, your 360 degrees radiology and healthcare partner. Shop for all your radiology needs, from X-ray machines to ultrasound machines, we have it all. At RadMed, we are dedicated to revolutionizing healthcare. We are experts in radiology and healthcare equipments, serving all areas in Kenya. Why should you choose RadMed? Firstly, we provide high quality and reliable modern technology hospital equipments. Secondly, we provide personalized support for every client. Thirdly, we have a proven track record in successful installations. Globe Care Hospital in Eastleigh, we delivered and installed an X-ray machine. Lydia Key Memorial Hospital, we delivered and installed an X-ray machine and a computed radiography machine. In Calvary Hill Hospital, we delivered and installed an X-ray machine with a CR. In Ziwa Hospital, we delivered and installed an X-ray machine with a complete CR. In Mwanzawetu Health Services, we delivered and installed a colour Doppler machine with 2 probes. Brooks and Cherith Hospital, we delivered and installed an X-ray machine with a CR. In Nanyuki Hospital, we delivered and installed an X-ray machine. Esobi Healthcare. Malkia Wings Hospital. Zenit Care Hospital. Nelly Nursing Home. Pro Care Cottage Hospital. Esther, a radiology entrepreneur. Itak Hospital.
Sternocleidomastoid muscle, and then just below the thyroid is where you get the longus.
Longus colli.
Yeah, the longus colli muscle. Hey, those things were not easy. You're not going 40?
They are not easy.
I'm saying they
He's
were
fasting.
not. When we,
They were not
You know, he's
because of
killing us
the
here,
way.
yet he's fasting.
when we
Because of the
started.
way you approach it.
Yeah.
If you get the introduction and get a relate to gross anatomy, then you come. Get to gross anatomy.
In fact, you see.
Welcome to RadMed, your 360 degrees radiology and healthcare partner. Shop for all your radiology needs, from X-ray machines to ultrasound machines, we have it all. At RadMed, we are dedicated to revolutionizing healthcare. We are experts in radiology and healthcare equipments, serving all areas in Kenya. Why should you choose RadMed? Firstly, we provide